Okay, and what I'm gonna do, since we could only do one day, is that we're gonna, of course, record it and send it out. So we'll do the same thing as we've done for the other videos. We'll probably I'll place it on YouTube and send you guys the link so you could actually watch it. Please, once again, if you do watch it, send me an email, name, and cert number. Megan?
Okay, so sorry, Dr. Lopez couldn't be here to start. Hopefully he makes it a little bit later. My name is Megan Berry. I'm the trauma program manager. I've been at YRC for, I don't know, 16 and a half years. So we're gonna go ahead and we're gonna start reviewing our cases like Romeo had said. All of this information is purely objective. Took it all from your guys' run sheets, from your guys' patches, from what data I could find within our own documentation. So we have a couple of different cases and they're very similar and interestingly enough, they happened kind of on the same day, but one happened at like 3 o'clock in the morning and one happened later on at like 10 o'clock at night. Very similar cases, but kind of different decision-making on scene. So I'm kind of interested to see what you guys kind of think about that or what opinions you might have. So this was just back in June. This happened down on Avenue C in County 14th. It was a 2-vehicle collision where a smaller pickup truck ran a red light or ran a stop sign that had a flashing light and they got T-boned by a full-size F-150. There were 3 patients in the F-150 and 2 patients in the smaller like Tacoma. So this is a photo that that we were able to get. This is the actual scene. So the F-150 over on its side, and then the Tacoma is pretty much annihilated. 4 out of the 5 patients did require extrication. One of the patients, from what I can gather, from the run sheets was already extricated when EMS got there. So this was primarily rural metro. I think San Luis and Somerton were involved in it as well.
I think initial was Somerton, San Luis.
It was rural Somerton and then San Luis.
San Luis. And Megan, chief is one of the ones that patched initially and they were the first on, well,
Oh,
technically
yeah.
first on scene, so.
No, rural got first on scene.
Okay.
Okay. Oh, you
Oh,
have it. You want to press play. I'm like, how do I get
Word.
this to play? Hey.
I'm sorry, guys, you couldn't hear that patch?
No.
Not at all?
It's over in the admin building.
Let me try it again because
In the human conference room. Yeah, we're just reviewing a couple of the cases that I had from before. So yeah, we're good.
you could hear us, but you can't hear the.
That is correct. Can
Okay.
only hear you, Romeo.
Okay. So, does anybody know how to fix this or? Yep, okay. Maybe because the computer's playing it. Maybe because of that, I don't know. I'm gonna stop sharing and see if I could play it on the, see if that computer will play it and then we'll start that. Sorry, guys, I should have. See if you could hear it that way. Can you hear that?
Okay.
No.
No, not at all?
Romeo, you want me to record it, play it, I'll record it, or then we play the
Would you mind? Yeah, let's try that. Okay, guys, technical difficulties, give me a few minutes.
voice recording.
So, Dr. Lopez is on his way. He
Okay.
said that he sent over. He emailed me a couple of presentations, but I don't know where I email. So that might be interesting.
Oh, sorry again. Okay, here we go.
Are you playing it? Cause I got nothing.
They couldn't hear it, so
Let me see if.
we're gonna try to play it, guys. Let us know. No, that's what I'm prepared about. How about if we do this? How about if you join the Zoom meeting on the,
Here's an iPad. You wanna join in the iPad?
Yeah, this one.
oh, it should be on your email. You get your email, it should be,
It's.
yeah, it's not.
Well, so while we try to troubleshoot this, basically the patch was kind of a pre-notification to the other patches, which I find extremely helpful when trying to get prepared, especially when you have multiple level ones. So patched in, gave us kind of a brief synopsis of what was happening. 5 patients, one that was a presumed DOA and the other one that was in pretty bad shape. And then they were gonna patch in once they were on their way. So this is, can you guys still see the screen?
No.
I think we need some test.
Oh, okay. So these are some more photos that are from the scene. So the F-150 is the one that had the presumed DOA. And then the other two, the driver of the other vehicle was the next kind of pretty sick patient. You want to minimize? Okay, so patient number 1, and so going in order of the the arrival times to the emergency department. So patient number one was the first patient to be patched in, and the first patient to arrive. She was probably the worst off aside from the patient who was dead. So this was a 50-year-old female. She was unresponsive, found in the Tacoma. They could smell ETOH on her. GCS was about 7. Once she got to the ER, it was about 6. Somerton's the one that patched in for her. They were at the scene at 21:22, departed at 21:32, and they arrived at YRMC at 21:40. Vital signs were initially kind of stable. She became hypotensive en route. She had an IV that was established. She was placed in a C-collar. Doesn't sound like she was on a backboard. And she had ECG monitoring. Once she arrived to the ER, she was immediately intubated. She had a 137-minute length of stay. So that's from time of arrival to transfer. Our goal for the state is 120 minutes. Sometimes things that can impact this, weather, flight. This patient was pretty sick, so getting her stabilized enough to be able to transport her. She did come back positive for meth, marijuana, and her blood alcohol was 196. Her diagnosis was she had a 6th and a 1st rib fracture, clavicle fracture, pubic rami fracture, a plate fracture, Lafort fracture, subarachnoid hemorrhage, and subdural hemorrhage. So it's pretty hard to break your 1st rib because you do have to break your clavicles. So she had, I mean, as you can see from the pictures, the impact was pretty big. She ended up being transferred to St. Joe's for the most part. We transferred most of our patients to St. Joe's or to Banner. Once she got there, it was determined that she had a mental health history. She was going through withdrawals. So then they had to manage her alcohol misuse. Neurosurgery consulted. She did not receive any surgical interventions. Ortho was consulted. They did go ahead and go in and plate her clavicle fracture. Plastic surgery was consulted. Her facial fractures were non-operative. She was extubated a few days after the incident. Again, she was going through alcohol withdrawal. So they started her on phenobarbital. And she was eventually on the 30th. So less than like about a week later, she was able to be discharged. She was clear. So they discharged her to a psych facility. And she has not had any visits to us since. So I don't know really after this what her outcome was.
Okay, here's that patch for this patient, correct?
Yeah.
Okay,
So what do I do?
unmute it and we'll see if they can hear it. Please let me know if you could hear it. We're gonna play it. It's gonna be like that.
Hi.
No, we're gonna get that echo.
Okay. Well,
Oh, what if I step outside the door? Oh, cause it's the echo, right?
Sorry, guys, we're gonna see.
all right, let's go ahead and move on. So that's patient number 1, basically patching in. And again, they re-verbalize that there's going to be multiple patients coming from the same accident. There was a little bit of confusion. And even when I initially was looking at this case, how many patients there actually were. So somewhere in one of these patients' charts, it got dictated that there were 2 deaths on scene. And then we got the 5 patients who came into us. So it was kind of confusing, were there 7 patients or 5 patients? And then finally going through and really kind of digging deep into these cases, we were able to figure out there was only 5 patients. Second patient to come in was a 52-year-old male. So he was the rear seat passenger, or he was found in the rear seat of the F-150 that was rolled over on its side. He was able to kind of be extricated, just a little bit of assistance to extricate him. He was complaining of some chest pain, some shortness of breath. Diagnosis ended up being he had several rib fractures, so that makes sense why he would have the shortness of breath. Vital signs though remained stable, and he was admitted. He had surgical consult. Dr. Lopez actually consulted on all of these patients. He was admitted for about 4 days, and then he was able to be discharged home with physical therapy. He kind of was a little bit reluctant to do his incentive spirometry and all of that kind of stuff as well. But eventually he was able to safely be discharged.
Megan, do you know the cause of why he would be braiding? And I see that he remained
I
braiding throughout.
don't, so I can look into, that's right, that was the other thing. He was extremely bradycardic and the patient denied having any kind of history of that. I can go back and look in his chart and see if he had any kind of, I don't recall seeing a cardiac consult on him or anything. So I can go back and look and then I can email it too. Do you want to keep playing the patches if they
That's,
can't hear?
at least for them, or?
Yeah. That's what happens when you show up. Okay, and so on these cases specifically, I included the scene times, just to kind of get your guys' thought on patient number 5. So patient number 3 was a 30-year-old male. He was the front seat passenger of the Tacoma. He's the patient who was ambulatory on scene. Self-extricated prior to EMS arrival is what I was gathering from the run sheets. Initially, he was a little bit altered. GCS was 14, but prior to him arriving to us, his GCS had improved up to 15. Rural Metro transferred this patient in. He had 2 large bore. So this patient, ambulatory on scene, had 2 large bore IVs. He was placed on 2 liters of oxygen, and he had a 300 ml bolus. His vital signs were completely stable. He had imaging, just like patient number 2, imaging, treated for his pain. He was also admitted. So this patient, he came back positive for meth and marijuana. He was admitted, he had a right ankle fracture. He was treated non-operatively. He had follow-up and consult by surgical services and from orthopedics. This patient was able to be discharged home on day 5. It sounds kind of like with this patient, he might have had a delay in being discharged because they were waiting for him to have like a walker for assistive devices. And that patient later on, it was documented that he had just met patient number 1 that very day. He didn't really know her very well, allegedly. And that's kind of what came out as the police were interviewing him in the ED. Patient number 4, probably the most stable patient of them all, even though she didn't self-extricate. It sounds like she was maybe kind of stuck. She was the driver of the F-150. She was restrained. She was not in any immediate distress per the run sheet. Chief complaint was left wrist pain, chest pain, left hip pain. Rural Metro is the one that transferred her or transported her to us. She had a C-collar in place and she had an IV established. Her vital signs were completely stable. As we drew her labs, her troponin levels were noted to be kind of elevating. And I think they got up to like 600. So she was admitted primarily for a cardiology consult. So she had an echo and all that workup while she was admitted. She also had a broken toe, so podiatry consulted on her. As far as I can tell, she was non-operative, and she was discharged home after 2 days. Later on, it looks like her outpatient, she had some follow-up and they found that she also had a radius fracture. Okay. And then so patient number 5. Patient number 5 was the last patient to be brought in. This was the 75-year-old male. Rural Metro transported him. He ended up getting to YMC about 22:10. All 4 of the other patients arrived to us prior to 2200. So what Rural Metro was on scene at 21:43 per their run sheet, and left at 22:10. He was actively, based on the run sheet, they said he was being actively extricated on this crew's arrival. Allegedly, when they followed up with the command on scene, they said there was a faint pulse, agonal, unresponsive. Once they got him extricated completely, there was no pulse noted. So ALS was implemented and patient was asystole. He was given 3 rounds of epi en route. When he arrived to the ED, trauma was there, ER physician was there. They immediately placed bilateral chest tubes, intubated the patient, gave another 3 rounds of epi, and time of death was at 22:17, about 7 minutes after his arrival. I'd like to dive deeper into patient 5.
Yeah.
Okay.
Doc, can you hear us?
Yes, can you hear me?
Yes, sir.
So do we know from the run sheet what other EMS treatments were provided on scene?
So for patient number 5, there wasn't a lot documented on the treatment, and even for patient number 1, unless I missed it, there was no documentation of like airway, or anything like that that I noted.
I thought
Do
I
we
saw-
know what kind of airway they had, or was it BLS airway at that point?
Thought I saw an IGEL place up that way.
So
On the
I will have to go back and look. I don't recall seeing an airway documented,
Okay.
but there, I could have missed it.
Okay, I thought I saw an IGEL doc on patient number 5.
Okay. I'm just curious as to anybody in the, I can't see you guys, but anybody in the audience, if anybody has any thoughts on how that patient was handled.
I mean, even
Any opinions?
Part, I mean, yeah, if he did have indeed an IGEL, I mean, that's IGEL, capnography, just make sure that we were getting good airway.
or at least see the waveform and what levels you're at.
The one thing that I was kind of curious about, and I have never been on scene, I don't have any clue what that would be like to actually do true triaging and label a patient as Black, even though they're still alive. Like, I don't know what that's like, but given the times, and that's why I kind of included the times on this, it seems like this patient was kind of left for the end because the other patients were likely gonna be more survivable and limited resources.
Yeah.
But my kind of thought process would have been 21:43 to 22:10 or 22:01 when the patient departed. That's a long downtime if he didn't have a pulse. And from a resource stance, would there have been a consideration to call for time of death on this patient?
Exactly. That's what I'm getting at. And hopefully everybody in the room sees this in hindsight. You have, I mean, I don't know what the initial response looked like, but I would imagine that the need outstripped the amount of resources at the beginning. And so you guys should all remember that you have your ramp triage page that shows you how to prioritize, and you should really be practicing how you play, meaning that even though this may not come across as a mass casualty, like a school bus full of special needs kids or something like that, it does start off as a mass casualty anytime that your need is more than your resources. And so at least for the initial response, probably the first 10, 15 minutes, that I'm imagining that was the case. And this is somebody who by ramp triage would be considered, Black. And now, even if you had all the resources and you had 2 paramedics and an ambulance and an engine for every single one of these patients, I'm asking myself, why was patient 5 even transported? That should have been a field termination, no question about it. You have somebody who has 0 chance of survival, and the decision to transport this patient not only further taxes the response on scene, but then it really jacks up the trauma center, the hospital, because they're expending resources that they otherwise shouldn't have expended. And so this is a patient. And then the other thing is that when you look at the description of what happened, and unfortunately the documentation is lacking here, if you were to start resuscitating this patient because they technically lost pulses while, quote, under your care, that's all good and well. But remember that aside from the airway, you can also consider, you don't have to, but you should at least be considering strongly bilateral needle chest decompressions in the field and not waiting for the ER to do that. Because if that patient's going to have a life saved, it's going to be by airway and it's going to be by decompressing the chest. I'm all good with the iGel selection. That's great. I don't need these people intubated. I don't expect them to be intubated through the trachea. But if you're going to go there, consider bilateral needle chest. But even if that fails, your guidelines allow you to terminate efforts on this patient, and that should have been the move taken by these crews.
Sir,
So Megan, little bit about the call. I was there and I was in the incident command because Rumach was there first. So I asked their incident command, what do you need from me? And he said, well, since we're extricating on 2 vehicles, we'll be on this, you'd be on the other one. And that's when I said, do you want me to give heads up, because normally for Somerton, that's what we do. Anytime we have multiple patients. That's when I was told that there was a DOA on the truck. So when I patched it in, I said confirmed DOA. So that's where maybe the confusion came in. That I said there's a confirmed DOA and then there's 4 patients that you're gonna be getting. And then later on, once we got our 2 patients, I came back to command. And then they said, well, they felt a pulse on the patient number 5. So they're gonna continue with their extrication and transporting. So that, the one that I had said was a confirmed DOA ended up being patient number 5. Because like I said, once they got the other 2 patients, they felt the person that was inside say, hey, there's still a pulse on patient number 5. So that's where the decision was to continue the extrication, got him out. And I think as they were wheeling him into the ambulance and they felt again, that's when they didn't feel a pulse.
Also, so a pulse through on the gurney.
Yeah, once they got him out and they said they still had a small pulse and they put him on the gurney, and then they said, once they got in the ambulance, I think there was no more pulse.
Okay, so in the run sheet, it did say that as soon as he was extricated, but it didn't specify at what point after extrication. It just said, once the patient was extricated, he was boarded and noted to be useless.
So, and maybe if not for future references, if some same situation, maybe when I patch, we give not say to confirm, because it's not being confirmed. And then maybe give you like a heads up, like, hey, be advised that confirmed that it was actually being
Possible.
transported and now it's total of 5 and that's the total number of patients.
So
So they
that,
don't have that confusion, like you said, the 5 plus the other 2 DOAs or.
So listening to the patches made it make a lot more sense, but something got lost in communication in the actual physical report between the nurse and the medic. And that's where on one patient, they said there was like 2 dead, and then you have ER physicians dictating there were 2 dead on scene, and then the additional 5 patients. And so it's like the telephone game, and it just kind of got all messy. But when you can go back hindsight and listen to everything and re-review everything, yeah, it makes sense that there was only 5 patients.
and that's what I was gonna say, in the patches, that's where I think the confusion started getting a little bit mixed up, because ambulance are painting the story. Maybe, hey, this is coming from the same accident, you know, or mass casualty or what event or whatever, maybe we need to identify that to where it's like, they don't repeat how many patients they have, everything else.
Or even maybe let them know, hey, be aware that I already made a pre-patch or they already know. Especially we have, I don't know if Rural Metro does the same thing, Yuma does the same thing where they do like a heads up patch. Like we've done it for years.
Oh, yeah, we do, but everybody's different, like you say, everybody's different. So we do have the radios, the mobile radios, and I don't know if you went to a certain command channel or something.
Yeah, we run
Yeah, so maybe identifying that to them so they could actually hear the incident to where, like transport unit, like who's ever in sending the units in or whatever it is. Maybe that's the communication we need on those mass casualty ones, to where it's like a direct contact. Hey, there's an ambulance leaving, right? I mean, there's another one leaving. We have that conversation to where we don't lose anything in translation, but with the. Yes,
Are you seeing? Like, tell who the ambulance? is leaving?
maybe the RC, when you patch in like that, we should have, like, maybe we have the portable radios that we could go on the channel. On your.
Ah, okay.
So
Like
better
that
conversation.
incident, we were on mutual aid 5. So your RC go to mutual aid 5, so.
And yes, but I mean, we haven't had the full training, but that's one of the things I think might
Okay,
do better, right? I mean. That way there's direct communication, there's no, hey, we just got a patch saying that there's 5 patients, can you confirm? Right, and that conversation can go on there.
okay.
Or something like that, I mean, yeah, but we can work on it on the committee and get that going, but yeah, it created some confusion with every patch saying something different, so.
Doc, did you have anything else on this one?
I mean, not for nothing, but as far as, in my view, each individual unit, the paramedic on that unit is responsible for that one patient. And I'm not sure that I would expect them to have a more holistic view of what's happening on the entire scene. If this is going to be depending on again, the resources that are on scene and how command has divvied up sectors, I would expect the transport sector to have that holistic view of saying, I've just sent 5 ambulances with 5 patients, and it's my responsibility to notify the trauma center of that information. Because that you have to unburden those individual units that are providing individual patient care.
So would you recommend then just one patch for all the patients or?
Nope. No, that's not what I'm saying. I'm just saying that, you know, if the patch is coming from the single unit, like an ambulance with their patient, I can't expect them to sort of be the ones to report, I am one of 5 ambulances coming into you.
Yeah.
If that makes sense.
No, it does.
Yeah, yeah.
Gonna go to-
Okay, so this scenario, very kind of similar, multiple patients in one accident, happened on the same day, but early in the morning, about 3:28. And this was YFD primarily who was on scene. I didn't see any other mutual aid or anything. So this was an MVC in which a 16-year-old male was driving intoxicated, allegedly, and he hit 2 vehicles before he ended up striking a brick wall and going into a house. There was an 18-year-old female who was riding passenger, and then there were 3 additional patients in the rear seat, 2 13-year-olds and a 12-year-old. The 18-year-old and the 16-year-old were called on scene. And then one of the 13-year-olds was significantly injured, and we'll talk about them. But I found this interesting because generally speaking, people have a hard time calling, it seems, calling time of death on pediatric patients on scene. Frequently these patients end up being transported. So the previous case where we had the death on scene that we brought in, and then now we have the 2 pediatric cases, I'd be interested to know what, I don't have any information on those 2 patients, so I don't know exactly what transpired.
Again, the field termination for trauma does apply to all ages. And so if indeed those crews arrived and there was no pulse and no spontaneous respirations that were not corrected by opening, you know, basic BLS maneuvers to open an airway, then those patients are dead.
Yeah, and I talk to Romy about it all the time, regardless of what their age is. I'm like, why did we bring this patient? Because then their time of death is like 2 minutes after arrival, and it's just a lot of resources. But these patients were called on scene. So the first patient number 1, this was the first patient to be brought in. He was the most severely injured. This is a 13-year-old male. He had been extricated from the car by PD. Patient was found unresponsive, side-lying with irregular breathing. He ended up having decorticate posturing. Spinal immobilization was applied. He had from what I can gather from the documentation, it was a non-rebreather that was in place. He had 2 IVs. His vital signs were actually stable for being completely unresponsive. They were dispatched at 3:28, arrived at 3:38 to the patient, and departed the scene at 5:53 or 3:53, excuse me, and arrived at YRMC 5 minutes later. Patient was immediately intubated, had imaging, and his total length of stay was 126 minutes. They started preparing him for transport before we even had imaging. He was there for like 30 minutes, and they started trying to get him transferred. He had head bleed with shift herniation. He was positive for marijuana, and his alcohol level was 80. He ended up being transferred to Phoenix Children. Once he got to Phoenix Children's, he had a GCS of 3T. He did have a gag reflex. He was taken directly to the OR with neurosurgery for evacuation, and then admitted to the PICU. As of today, he still is at PCH in their PICU. Family did not want to terminate any efforts. They tried to have that discussion about palliative care, and family wanted to continue with aggressive care. So he's been up at PCH this time.
I think that repeats, right?
Yeah, so, for those of you who are on Zoom, the patch did say, they did make reference that they were bagging the patient. Okay, so this was, and I'm guessing based on the documentation for the next two patients, that the 13-year-old male was behind the passenger seat. And based on one of the run sheets, they made reference that there was significant damage, more damage to the passenger side, which sounds like he got the brunt of it. 13-year-old male or female, excuse me, she was sitting in the middle back seat. She says she was restrained. There's a deformity to her right femur. GCS was 15. She had full spinal immobilization. She had an IV in place, and her vital signs had remained stable the entire time. This patient did not require any kind of traction or anything. They were kind of able to position her in a means of comfort, and then transferred her to the ED. Once she got to the ED, this was the last patient to actually be transferred out of the hospital. She had pain management, she had imaging, her potassium level was really low, like 2 something. So we did replace her potassium. Her length of stay was 140 minutes. So she had the femur fracture, her alcohol level was 81, and she was positive for marijuana. She was transferred to PCH. She was taken directly to the OR with ortho once she got there. And then she was able to be discharged home. It says 6/22, but I feel like that's really, really soon, the next day. Did you want to listen to this? I do kind of have a question just thinking about this case and the case prior. So all of these patients were coming in emergency traffic, but she was relatively stable. This patient was relatively stable. And there were a couple patients in the other group that were pretty stable. Is it a common thing to just go emergency traffic when you have a few that are really unstable in the same accident?
I think that's our
Yeah, I
protocol,
think
right?
that
Yeah, our,
Criteria, trauma
Yeah.
criteria, it's a level 1 trauma.
They're-
Because of
with the deaths.
Because of
but
mechanism.
if they're in a vehicle, they all become.
Okay, patient number 3. So this was a 12-year-old female. She was sitting behind the driver's seat. She was unrestrained. GCS was 15. She arrived to YRMC as the last patient at 4:03. She was in spinal precautions with an IV in place, and her vital signs were stable. Doesn't sound like she had a verbal patch that came through. It was an ECN. She ended up having a grade 4 renal hematoma. She had a temporal hemorrhage, mandible fracture. Her ETOH was 61, and she was positive for marijuana per the patient. So we didn't do a drug screen on her, but she admitted to EMS that she had been using marijuana. She was also transferred to PCH. She continued to have a GCS of 15. Her vital signs were stable. They took her to OR to repair her mandible fracture and all her facial injuries. And then she was admitted post-operatively. She was discharged on 6/23 with her parents. And I didn't find any reference that they did anything as far for the renal hematoma.
So a quick go back question. I think it was excellent to kind of ask about what determines people who are brought in emergency traffic. I'm assuming that means what we're saying there is people who are brought in lights and siren. Is that correct?
Yeah.
Okay. So I just wanted to ask for the administrators in the room, is that based on the trauma triage guideline that we call it a yellow? if there's a death in the same passenger compartment, or is that more of an operational protocol that each fire department has?
Death in the same compartment is criteria for us for trauma yellow.
Yes, that's what I'm saying, and it is for EMS as well, but that's just a destination decision. The trauma triage guideline doesn't have any commentary at all in terms of who's brought in lights and siren and who's not. And so I think it's a valid point. I think that the agencies in the room should take a look at that and really rethink who it is that they're transporting lights and siren, because that does increase risk to crews and patients. And again, it kind of creates an additional stress on the receiving hospital if there is not a physiologic reason that a patient needs to be transported lights and siren, then we really need to make sure that that's not some misguided policy that we're following. Because if you look at that guideline page, it says nothing about how you transport them. That guideline page is about where you transport them.
I agree with that. Okay, did you choose, Dr. Lopez, did you choose different cases than,
I think.
The one they sent you?
I think I chose one that you sent me and then the other ones were all different.
okay, here, let me,
I just don't have a fancy looking PowerPoint like yours.
so hopefully I got this sent over
I
to my.
jumped on like 5 different computers trying to access Outlook and each one had a problem with it.
Well, ever since they updated the email thing, I can't figure out how to log into my work email, so hopefully I can log into my.
I sent it to Romeo too.
Oh, okay.
Yeah.
You wanna stop the share real quick? That way. Okay, guys, we're uploading the cases for Dr. Lopez.
Should have for Outlook, right? Are you able to go through this?
Yeah.
Send it to myself too, just in case, because
Well, Romeo's logged into the Zoom, and so that's why I was like, okay, if I go this route.
I did most of these cases last night, but I wanted to add one more for TBI discussion. Oh, yeah. Yeah, would you have to like?
More than one way to beat this.
Before you share, go back to the Zoom and then you can.
Yeah, it took me like I was trying to figure out a way to get it through, but. You know, you don't have access to Gmail here, so I
Oh,
can't.
Megan, go back. It says share sound if there's. On the, where you said.
Oh, no, it looks like it's picking up.
Go right there again, go share. There it is. That's why.
Well,
Let's do it again.
I'll do it again, listen to the badges, like,
Yeah.
figure out our problem.
So easy, huh? So easy.
Okay. That's a good question, is it on?
Let's see.
Can you guys see, it should be a blue presentation?
Yeah, there you go.
Yes.
Okay.
Awesome. All right, guys, I'm Dr. Lopez. I'm the trauma medical director here at U Regional. I'm actually born and raised here too, so it's kind of a native human. Did my rounds. I went from here to Phoenix to Arizona State University. I got a Bachelor of Science in Biology, and I went to medical school at the University of Arizona in Phoenix. Then went across the states to Pennsylvania to Lehigh Valley in just north of Philadelphia, where I did my general surgery training, and then I went and did a trauma critical care training year And between the two, I worked for a year up at East Stroudsburg, where I was a level 3, which is what we are. So I have a little bit of experience on what level 3 should be. And so, and I came on board here, Dr. Decky happily abdicated this title to me. So I became in charge of this program, trying to kind of steer it in the direction we want to build out. So you guys are part of that because it's not just hospital what we do, so we do pre-hospital. So this is very important. That's why we try to create some sort of relationship between the hospital and our EMS crews, because it's very
Sound
important.
is better right
Oh,
there.
can you hear me?
Can you guys hear?
I speak pretty loud, so I don't know. Are
Yeah,
you guys
I
picking it
can
up?
hear.
Oh, awesome, perfect, okay. So, and you guys obviously know Megan, she's our trauma program manager, so she and I work together to kind of help build out policies, help build out protocols, but obviously we try also work out with the community centers, depending what we need from you guys to kind of like create a nice relationship, so you guys know what we need, we also fulfill what you guys need as well, so, see if this thing is working.
And Dr. Marin is on. He's the EMS medical director.
Oh, perfect. Hi, Dr. Marin. Nice to meet you.
Likewise, thanks for joining us.
So, I have no disclosures. I'm I don't know. I don't have anything. So anyway, so I wanted to, so just kind of a little overview. So we became an official level 3 center in October 2022. We have a 3-year accreditation, which means our accreditation is up for review next year. We are 406 beds here. We have 42 ICUs technically. Usually they kind of function on more like a third of that. But we have the ability up to 42 beds. So it's a pretty big hospital, even where I trained at, we had over 1,000 beds, but the 2 smaller hospitals we rotated at were less than 200. So this is a pretty sizable hospital, which is very important because we're kind of an island, as you guys already know that. So we have about 8 general surgeons that also cover trauma for us. Between our veterans like Dr. Decky and Dr. Chung, to some of our young surgeons, Dr. Tallman, Dr. Taywinkle. We have Dr. Gaudet starting this September. I'm kind of in the middle where I've been here for a few years, but I'm not that quite fresh out. And then Dr. Green also comes down from Minnesota. She covers a week at a time at the hospital. So we're all kind of in charge of running our trauma programs here, whether patients coming in critically ill need to be assessed and treated. So we also have now multiple specialties, which is kind of a nice growing. We have vascular, spine, orthopedics, urology. Technically, we also have ophthalmology. They are available by phone. Oftentimes, it kind of takes a lot for them to come in, but they are available in case you ever need anything. You can always reach out to them. And obviously, our general trauma surgeons. So our main role here for level 3 is to evaluate and stabilize patients. And we're trying to figure out those patients who can stay here, meaning patients we can manage here. We're also trying to determine those ones that need to be transferred immediately. Obviously, head injuries are still one of those ones we have to transfer out. So we try to identify those quickly, get them out, because time is brain, just like a stroke. So we try to focus on trying to expedite that transfer as long as we get that diagnosis. We also are part of our roles as level 3, who have to constantly evaluate our practices and improve, essentially, because that's part of a healthy programs. You constantly have to change and adapt to what your community needs are, which is kind of why we have this sort of ongoing community outreach projects and trying to kind of communicate with our EMS crew, with our other subspecialties and things like that. So that way they know what we need from them. So that way they can be able to offer that. If not, we find another avenue for them. So, and then our goal is you want to maintain a high quality of care and then improve those areas of poor performance with quality improvement, process improvement. So that's kind of what we do here. That's what we're doing as a level 3. So just to kind of give you an insight of like what goes on in the background and why we do these sort of things. But anyway, I think always the best way to learn through case reviews. So you look at cases, kind of see what went right, what went wrong, what can be improved upon, what can be maybe better, even though it was good, what could be better. So we always kind of look at cases. A lot of these cases are actually pretty good. So I just thought it'd be kind of more of a theme-based discussion. So the first 2 I was talking about are pre-hospital mortality. So these are patients who are probably coding out in the field coming into the hospital. I'll kind of talk a little bit of some recent articles that I found last night to kind of go over and kind of explain what those articles kind of tell you. So first case, let me see if this works. So this was a 75-year-old gentleman involved in MVC. There was 2 other fatalities on the scene. Airbag was deployed. I think we didn't get the history of the seatbelt though. So the gentleman was reportedly unconscious. I don't know if you did this one, but those were the ones you sent me. So He was reportedly unconscious, but he did have a pulse. Once that he was extracted and placed on the gurney, he lost pulses, went into asystole. ACLS was initiated. There was no ROSC on by the time arrival to trauma bay. Sorry, that's my 12 p.m. Or 12 a.m. Misspelling. So I just kind of did the review of the patch, and it was 10-minute response time from the patch en route. You were at 21:24 at the scene at 21:43. Patient side 21:50, and then you left the scene 10 minutes later and arrived at the hospital. So overall, for the most part, about 40 minutes between the phone call, seeing the patient, and bringing him to the hospital, which is pretty good. That's a pretty good response time, especially with, you know, we have a lot of county space, so we have to travel quite a bit of distance sometimes to get to patients. So overall, I think this was really good overall response time for that.
So we did talk about this case and the 4 other patients, and we determined, because this is where we got confused at how many fatalities were on scene. He was the
It
fatality.
was,
Yeah, the other 2, there was only 5 total patients, so there was some kind of verbal handoff that kind of got miscommunicated, but there was only 5 patients and he was the.
But I'll maybe we'll see where kind of this our discussion leads. So yeah, so we did the full workup here. So we had predetermined, so this guy never regained pulses throughout this resuscitation, right? So from 21:50, when you guys were at the bedside or at his side, treating him, started coding him to the point that we took over, which is roughly around like 21:15, which is roughly about 25 minutes. As you reach that technically even 10-minute mark with a blunt cardiac arrest, the mortality almost reaches 100%. Which is why we're kind of like, okay, you know, how much are we gonna do with this scenario? Because we know that your chances to intervene and have a successful resuscitation is almost 0. And so we had predetermined when the patient arrived that we're gonna intubate the patient, means get a good stable airway, bilateral chest tubes to rule out tension pneumos. If you had ROSC after that, great. If not, we knew that at that point it was futile, because no matter what you do, his brain was already cooked, his brain was done. Because at that point, you sustained almost 30 minutes of hypoxia to that brain is no longer alive. And that's kind of why we end those resuscitation efforts, because even if you get a pulse back, they're brain dead. And it'll take another 2-3 days to figure that out, but generally that's what you see. And so that's why, so total cardiac arrest time is 36 minutes. So the thought process behind this is likely this was either, this could be a direct cardiac contusion that causes a fatal arrest, or this could be likely a tear of one of the major vessels that just exsanguinate and you're done. That you exsanguinate in 30 seconds and you're done. So that's why I said these are very, very, yes.
Dr. Lopez, sorry to interrupt you. Perfect summary. And again, our goal as an EMS system in with this particular geographic, the challenges that come with it and the level of trauma care available, our stated goal is that we need to be cleaner and more confident in our field termination of these patients. And as I said earlier, the crew could have considered bilateral needle decompression in the field, securing an airway, and I think the iGel was very appropriate to do so. But given the resources and the other patients, as well as what's been established in terms of pre-hospital evidence, this could have been a field termination as well.
Yeah, and that hopefully that was kind of one of the discussion points. And I kind of tried to leave it in a way where if you have good history that this person has been pulseless for an extended period of time, I think that's very appropriate. But if you don't have that history, if you have a very limited information, treat them as if that's the first point when you encounter them being pulses, that's minute 0. And that way it gives you that you are kind of the first person to identify that, and you're kind of moving from that point forward. But if you have good bystanders, present, they did a pulse check and they say, hey, I checked their pulse like 20 minutes ago and they're having, a pulse. It's a very appropriate approach. What I'm trying to do more than anything is protect you guys to do the right thing. Because like I said, at the end of the day, you're kind of limited with whatever you get information wise out in the field, right? If there's somebody out there who has a good memory, knows exactly what time they checked the pulse and everything, great. Sometimes you don't have that. And so at the end of the day, it's like, we're never going to fall if you bring those patients in and we resuscitate them here. Because at the end of the day, like, our goal is to just do what's right for the patient. And if we have no information, let's just assume, 0.0 is the time that you evaluated them and you found them pulseless. So that was kind of one of my learning points that I feel like was appropriate. In this case, like you kind of mentioned, I think it would have been appropriate given the time frame. But like I said, we had already predetermined, knowing what we knew, that this is what we're gonna do, and then if this doesn't help, we're gonna call it, because we knew that any other intervention would lead to no better outcome. It would be the same outcome, 100 times over. So, in very similar case, this is a different one. It's a 20, I think, did you go over this one, the 25-year-old?
You know,
Okay, so the 25-year-old who was supposedly riding his motorcycle at a high speed, lost control, hit a wall fence. There was bystanders present, but didn't do any sort of evaluation. They just saw it happen. So they just knew when it happened, but they actually didn't like check on him, see if he was breathing or anything like that. So, so they really didn't really have any much more vital history other than, yeah, we saw him crash into a wall. And so, by the time the initial contact was around 2:13 in the morning, it was pulses, PALS, ACLS was initiated. IGL was security, arrived at the hospital about 2:31. So roughly about the 18 minutes. It's not bad. The patient was intubated, bilateral chest tubes replaced, kind of like pretty standard. Someone's coding. The easiest thing to rule out is a tension pneumo. So we just naturally oftentimes put in bilateral chest tubes. The other thing you can realize is if when you put in one of those chest tubes, a bunch of blood comes out, now you have a source of bleeding. So now you can then initiate your MTP. So they initiated MTP for this gentleman because he had obvious, like a bunch of external sources of bleeding. He had an open femur, big lac over his face. So obviously hemorrhage was one of the other possibilities. So MTP is kind of our natural go-to for anyone who's in a hemorrhagic shock. So we initiate that. So he was in persistent PA. He had intermittent episodes of ROSC that would code again. Pretty acidotic. His pH was like 6.9. So it was kind of like you're almost kind of reaching that futility. But because you had like these intermittent ROSC, they were trying to get him to a CAT scanner to kind of prove what was going on before they they ceased all interventions. But this is one of the ones we're reviewing because I think realistically in this scenario, given this time frame, you probably could have called it after the second time he coded in the hospital and said, hey, he's been coding for 35 minutes and with intermittent pulses. Like this scenario is going to end the same way no matter what we do. But do you have a question?
Yeah, MTP?
MTP is a massive transfusion protocol site. So MTPs are what was designed and it's changing a little bit, but MTP was designed out of military data, came out in like the early 2000s. 90s, 2000s, I can't remember my dates on it. But essentially what they realized is that they have to resuscitate patients not only for their blood, but also their clotting factors and their platelets. Because when we bleed whole blood. And when we just give them blood cells back, they're just not going to clot. They just keep bleeding because they have no clotting factors, they have no platelets. So an MTP is a balanced resuscitation of appropriate 1-to-1-to-1 ratios of blood, platelets, and factors. And we have a built-in system here where we have 2 units of blood readily available, and every 15 minutes you get 2 and 2. And then intermittently you'll have like a cryo, which is your fibrinogen. You'll get your platelets as well. So eventually after the 45 minutes, I think there's a 30 or 45 minute camber. You get the full 1-to-1 ratio. So it keeps that blood volume balanced so they can clot. Because half the problem is when they can't clot, they'll just keep all the blood you're giving them, they're just bleeding down. So, but MTP, you'll hear that. If you ever hear that, that's what it means. It's a massive transfusion in a balanced fashion. Sorry.
and blood bank knows what to send. So all we have to do is call them one time, say, I need an MTP, and we just keep sending our runner. That way it's not relying on the doc saying, oh, give me this, give me that, give me this. It's just a consistent.
Until you say stop, and then it shuts off that line. But for on the EMS side, that blood that you guys collect on trauma alerts and stuff like that, it helps you on the background. So that blood work is gonna be, after we transfuse them, we wanna go back to what he's, that patient, right, initial. So that's part of that work that you guys do for us, so.
So just a little other details for him. So he did have fixed and dilated pupils on presentation. They were able to stabilize and get into CAT scan. CAT scan showed pretty catastrophic head injury. He already had uncle herniation. He had cerebellar herniation. So overall, this is a fatal event. Like this is non-survivable head injury. I think he coded like not so long after this. So we're in the midst of we're going to review this case, but my commentary review for this was you probably could have called this earlier because the way this was going, it was already kind of predictive. His pH was well below 7, where you're so acidotic that your body's not going to sustain itself. And so this just kind of confirmed what we probably already suspected. He had probably catastrophic head injury. That's probably what caused his death. And so he also had a small, I think, like transverse process fracture, a little neck hematoma. None of this would have caused fatality. It's that head injury that would have been. I think he had like so kidney lacs tend to be pretty hemostatic because they're between the back and the belly, so they actually have pressure on them, so they tend, if they bleed, they tend to bleed really slow. They don't expand very quickly. It's when you bleed into the belly, like from the liver or spleen, that you can hemorrhage. But usually kidney injuries, as long as they're sustained in that retroperitoneum, generally are considered stable. So that wouldn't have been the reason for this person's demise. It was that head injury. And then, so I guess he coded later on, and at that point, it was essentially futile because you have a non-survivable injury on your imaging. He's been resuscitated now at this point, almost over, I think, like 2 hours, or like short of 2 hours. Like, even despite his age, there's no way he's gonna survive this with any meaningful recovery. And so his time of death was 4/14. So, so we I think we talked a little bit about this. So the time of cardiac arrest is very important. And the reason being is that the longer you go from that point to sustaining ROSC, the less brain you're saving. And typically for blunt cardiac injury or for blunt cardiac arrest, it's about 10 minutes. For penetrating, technically it's 15 because that's usually blood loss. And so with blood loss, you can resuscitate them and get their pulses back much faster. But blunt cardiac arrest is really tough because those oftentimes are sheared vessels, head injuries, things that you can't easily fix. And so the classic data was 10 minutes for blunt, 15 minutes for penetrating. We kind of give them a little bit. We kind of go maybe closer to 20 minutes for blunt, 25, 30 minutes for penetrating. As long as we have some sort of efforts put in and we have no improvement, that's when we all feel more comfortable saying, hey, we tried what's like basic and necessary and we have no improvement. So, but that's why it for your guys' point, when we ask like time of cardiac arrest, that's why it's important for us to determine how much we're going to put into this scenario, because sometimes it is beyond futile on arrival. You say, hey, we've been coding him for 25 minutes. We never got ROSC. At that point, we can, you ask the crowd, the team there, hey, we'll do it for 5 minutes. Does everyone feel comfortable calling after 5 minutes? And then you'll get, yes, no's. So generally, like, it just helps us with those decision-making in the hospital. We talked about prolonged times in the ACLS, typically associated with poor survival. This one will come up in the article I wanted to kind of just briefly talk about, but the lack of ROSC on presentation is a strong indicator or predictor of mortality. So if you don't get ROSC, by the time you're coding them to the hospital, typically their mortality is like pretty high and they're unlikely to make it. So, and the reason I kind of bring this up is I would say always get your best accurate information you can get. And then assume, if you have no other information, assume the time that you evaluate them to be pulseless as time 0. So that way it gives you that protection that you guys are doing everything you can to help this person. Because sometimes we just don't have the available information to make those decisions. But if you have someone, oh yeah, this person's been sitting out there for hours, they haven't moved, and you get in there, they're rigor mortis, you're like, okay, that's we can all say that's probably beyond salvaging. But sometimes these things happen within 10, 20, 15 minutes, and you're like, what should we do? And I would say, if no one else has told you otherwise, assume that's time 0. And then, like I said, this is the biggest thing, except in a lot of these scenarios, the likely outcome is death. The survival rate for this is like 5%, 4%. In the old data, it was like 2%. And it's not to say it's everything you do gives that person one chance to potentially make it, but know that it's not because of your lack of efforts that they die. It's because of their disease process. It's nothing to do with effort or decision making. It's just the disease process that usually causes death. So I always say, don't ever feel like it's because of you guys didn't do too much or didn't do enough. This is just a typical scenarios. Comments on that one? This one's like the biggest one because I feel like this is like a big topic because you always see these, and these are always like the hardest ones to figure out. The other one's a little bit easier because like we'll kind of go over a little bit, but this one I feel like was a little bit more complicated. And I'm trying to just kind of highlight is just do your best with getting as much information because that's information that we are going to need. And then at the same time, don't ever feel like this is anything that was done pre-hospital. This is a lot of times these outcomes are just predetermined by something beyond us.
Was this patient wearing a helmet?
I can't remember, but I think he was. He was wearing like a bucket type, which I don't know. I don't know what the bucket.
We've had a lot of motorcycle
Yeah.
crashes in the last couple of months.
there was a note of a bucket type helmet.
Okay.
That's all I heard. Cause we review the charts and sometimes the chart's very broken in what you get. But there was one note mentioned that he was wearing a bucket style helmet. So I don't know if those are ones like open face, or if those are the full cage one. I'm not sure. But that's all. I
There was
got.
one motorcycle collision that we did have that had a bucket helmet on.
So, but
So can I just jump in real quick? So the things that are more striking to me about these two cases, I think the case with the 75-year-old man is up for more debate because, you know, there's some people saying he had pulses, some people saying he didn't. And so I could kind of see that being judged on the merits of, hey, we had a person with pulses a second ago and now they have lost them. So that's sort of an arrest during the EMS phase of care. And then to me, those are the cases where the sort of 10-minute, 15-minute, 20-minute rules about, you know, how long is it going to take to get to the trauma center? Is it blunt mechanism versus penetrating mechanism and all that? But the second case with the motorcycle rider, I think, is about as clear as it's going to get for EMS. In the world of EMS, if you arrive to the scene of a trauma patient who's got a blunt mechanism of injury and you found them to be pulseless and apneic, you can actually withhold all efforts from that patient because their survival is going to be zero across the board. And I think the EMS data is very clear on this. It's open to debate if they code while under your care. And that's really where you need to be making some tough calls in terms of, is this going to take, you know, more than 15 minutes of transport time to get onto the trauma bay or not? And then certainly if you don't have any ROSC or anything like that. And for medical cardiac arrest, as well as trauma cardiac arrest, the data is actually put into the perspective of, does the patient have ROSC prior to even transporting? Because if they don't, if you're deciding, I'm going to transport this cardiac arrest patient without ROSC, the chance of survival across the board is less than 1%. And of those who do survive, they're neurologically devastated. And so that is just simply not the mission of EMS, is to try to bring these folks to the hospital with ROSC. The mission is more focused than that. It's really about getting alive patients to the hospital that are going to go home alive with intact brains. And so EMS is really trying to do a good job, a more thoughtful job of evidence-based termination in the field. And I think trauma is really where it's going to be most important, because this affects not only the hospital resources, but the EMS resources as well in very rural communities. And then all this, you know, driving around the county with lights and siren for cases that are futile. So we need to be very careful with that, with that understanding.
well, that's good to know, because like I guess at the end of the day, I was trying to make sure that you guys are protected if you guys decide to bring someone in. Like, we're like always, I would say we're always happy to just help assess that determination, because we usually can end efforts pretty quickly if we determine it's futile. But I agree, like a couple of the articles I had are recent, they make it look a little more like sunshine and rainbows about this, but in reality, like the data just tells you exactly what you were just saying. The mortality for these is extremely high. And so, especially in these patients patients who arrive to a trauma center with no ROSC, their mortality is like almost 100%.
Yeah, and I mean, when it comes to liability, it has to be, it's one thing to sort of think about it in terms of, hey, you know, we need to make sure our medics are protected against liability if, you know, in case somebody perceives that they didn't do enough. But imagine the liability of transporting somebody who is dead, who's going to be, the documentation is going to show that they have an unsurvivable injury, and the ambulance crashes, you know, and takes out, you know, additional civilians, or heaven forbid, you know, a couple providers in the process. That's actually where the liability risk is highest, I think, and there's precedent to account for that.
That actually brings a good point. I didn't think about that, because I was thinking about, like, you know, just seeing the hospital, there's nothing in the way, everything's safe, don't worry. But in reality, you're right, that there could always be, because you are rushing to get somebody to a hospital as quickly as possible, there's obviously risk with that too. So I think you bring up very good points in to say that what we all know and we all understand is that patients who have no pulses, their chance of surviving without ROSC, like you said, even prior to transport, is pretty low. So maybe we can come up with, we can kind of come up to agreement where we can maybe do like a little bit of a policy where we can say, hey, we all can agree that if this is the scenario, we can call it out on the scene.
We did.
We did that?
Yeah, we have all that. Everything,
Okay.
all of that's done. It's all based on national policy guidance from American College of Trauma, American College of Surgeons, as well as the National Association of EMS Physicians. There's policy statements on all of that, and that's all baked into the protocols as they are written today.
So what are the thoughts or recommendations? Sometimes when I'm looking at some of these patients, and we've had several patients recently, like I said, we've had increase in motorcycle collisions and they've been bad. Where EMS will get on scene, PD might be doing CPR. Or they get on scene and they say, oh, well, prior to extrication, we felt a little bit of a pulse, but then once they extricated, they were completely pulseless. If bystanders are doing CPR, is it recommended for EMS to then continue that and transport, or
No.
can they?
No. So the way the language of the guideline is written is from the perspective of the trained rescue professional. So if the EMS crew responds and they put hands on the patient and they are apneic and pulseless per the paramedics evaluation, you're done. Regardless of whatever the civilian bystanders have been doing, or PD for that matter. Now, if an EMS provider put a hand on the pulse and the pulse is present, and a 10-minute extrication has to occur, and then the pulse is absent, that's different. And then you can assume that the pulses were lost sometime at that point, and that's where your 10-minute timer starts for blunt trauma, or your 15-minute timer starts for penetrating trauma. That's fine. And we can talk about those timers all day long. But if the first trained professional rescuer is on scene, regardless of what happened before their arrival, and the patient is pulseless and apneic with a blunt mechanism, you're done.
Yeah, that clears up a lot more. That's much better than, yeah, because I was tempted to go down that route, and I was like, well, let me, because I didn't know what we had on file, but it's good that we have all that stuff preset in policy. So at least it makes it easier when we review these cases, we could say, hey, this is probably a good pre-hospital call. So yeah, so in that back when that 25-year-old agreed, like if he was pulseless, and if that's the policy, I think it would have been reasonable. But by the time you did your 10-15 minutes of intervention and you have no ROSC almost to call it at that time.
Yeah.
That person's not going to survive, and no matter what you do for them. So, man, that's kind of, so these are this is a study in 2016 from two registries, and essentially what they were looking at is looking at regional differences, management outcomes, pre-hospital cardiac arrest, and whether there was an ACLS procedure that led to survival. And they included 2,300 patients. They're mostly young males in blunt trauma, but only 145 actually survived, which is about 6.3% in this study. 2 hospital discharge. They didn't highlight their morbidity, whether they are functional or going to a transitional care for long-term care. Like, they didn't really highlight that. So this is just saying that they had a pulse when they left the hospital. Doesn't mean that they were walking, doesn't mean they were talking, doesn't mean they were eating on their own. So they were just trying to say like, hey, maybe the survival could be a little better, but the other drawback is, at what cost. But the typical reported survivability for this is around 2%. As I said, 2% of people with pre-hospital cardiac arrest and arriving at the hospital without ROSC, because the mortality was, like I said, almost 100%. And so that was kind of one of the big highlights where they said you have to have vitals or ROSC really at the time of arrival that will actually increase survival. That's the only thing they found in their study that actually showed a survival benefit. It was ROSC upon arrival. And then the other one that came out, this was from Europe, and this was from 2021. They did actually look at neurological outcomes, and they kind of found the same thing. Mortality for these type of injuries, it's like 97, 98%. It's really high. But the people who did survive, like favorable neurological outcome was only like 40%, which means that only 40% of those people who survived actually have some sort of meaningful neurological function. That means over 50% of them end up being some sort of persistent vegetative state, or on the ventilator for the rest of their life, or maybe paraplegic, those sort of things. So not to say that that's, you don't want to dictate quality of life, but it just sort of highlights that this is a very bad, when this happens, it just leads to bad outcomes no matter what you do. They kind of try, if you read the article, they try to make it seem a lot happier. Like, oh, look, it's not as bad as we thought it was. And then you're like, oh, it sounds just as bad as I thought it was. And so I just wanted to kind of highlight these because it tells you that no matter what you do, sometimes there's just things that are out of our control. So the last two I had were a little bit different. So this one is a 29-year-old got multiple shots. I think this guy got shot by the police officer. He was tachypnic, hypotensive. He had multiple gunshots. He had difficulty breathing. SATs were in the 60s. They did needle decompression, I think on the left side, improved his SATs to the 90s. So EMS arrived around 7:42. They had their initial patient contact. I think the cops had him in like cuffs. He was
Yeah,
like
handcuffs on.
bleeding from his axilla. So they left the scene like not no more than like 11 minutes later, arrived at the hospital within 6 minutes. So very quick turnaround. So within like 20 minutes they're at the hospital. So in the hospital here, generally when you have patients who are in this sort of state of critical injury, it's always better to stabilize their airway because you don't know how well their oxygen, you know, how well their CO2 is. So we always secure their airway better as we intubate them. We initiated our massive transfusion protocol. They checked the FAST, which is just an ultrasound evaluation of thoracic abdominal compartment looking for blood. You're kind of looking for intra-abdominal or intrathoracic bleeding. You can also see pneumothorax with this as well. The only thing they decided to do was a chest tube on the left side because he had obvious decrepitous and he had the needle decompression. So vascular, luckily we had already had vascular here, so they came by to help evaluate the axilla. They didn't see any obvious like major arterial vein. It was just a bunch of smaller veins that were bleeding. So they ended up packing it with quick clot. They got a CTA to be able to evaluate that. So for the most part, obviously A is negative. The CT of the neck did show a pretty bad fracture, one of the vertebral bodies from the gunshot. He had a big neck hematoma extending from that left side of the neck down to that upper chest, probably into that axilla. They didn't see any major vessel injury, so they kind of ruled that out with the CTA. He also had a few other, he had bilateral pneumothoraxes, contusions, rib fractures, and he had one magic bullet that missed his entire pelvis, went through the scrotum, didn't hit anything, but did fracture his pubic ramus. So this actually was planned to go to the OR because of the massive bleeding he had from that axilla, but they were able to get good hemostasis, and St. Joe's had already accepted him because of the vertebral artery or vertebral body fracture. So that would have needed gone regardless. And since he had reached the stable point, means that he's hemodynamically stable, we're no longer just like flooding him with products. They felt it was safer to just let him go than to explore him here. But kind of the highlight of this case really was this is like a hemorrhagic shock. And I wanted to highlight that initial assessment was actually really fantastic. They came in, they assessed the patient, noticed that he was tachycardic, hypotensive, difficulty breathing, SATs were really low. They put a needle decompression, got some fluid started for him. And by the time he got to the hospital, which was very expedient, and we intervened, we were able to stabilize him rather quickly. So I think he didn't get that much products to get him to a stable point. But this sort of highlights hemorrhagic shock is probably one of the other things that you guys can intervene on. Obviously, anyone who's bleeding, if you guys can control that source of bleeding, like if it's like a big open femur fracture, tourniquet, or some sort of way to kind of bind that to minimize blood loss. We do generally nowadays shy away from fluids in the hospital because we have access to blood. Out in the field, obviously a little bit different. Yes, all you have access to is fluids. So fluids, immediate fluid resuscitation just to maintain volumes, maintain perfusion is the most important thing. But this is a kind of nice case because it was early recognition of a patient who was in obvious hemorrhagic shock and obviously possibly tension pneumo too. And they intervened very quickly, stabilized him because otherwise had none of those been done by the time he got to us, he probably could have been coding. And so that's like, because his heart rate, I think we're in like 130s, 140s, blood pressure like 70s over 40s, like just really, really bad shape. And so by the time he got to us, he was a little bit more stable. So when we intervened, we were able to stabilize him further. So one of the, go ahead.
One of the medics had a question.
Yeah.
So this patient, I don't know what it looked like when medics got on scene, if he was fully like handcuffed, but when he got to us, he had a handcuff on one wrist.
Oh,
So I don't know at what point, because it was all very kind of a little,
yeah.
yeah, there was a lot going on. So I don't know at what point if he came in and he was fully cuffed or if he just had one.
Yeah, because the way I read the run sheet was that it sounded like he was fully cuffed, but I don't like, it didn't describe he was like cuffed like this, or cuffed with one arm to like some sort of, you know, bar. I just didn't, it just seemed like he was like under detainment.
Yeah.
I just don't know to what extent. And so I would hope the police would have been like wise enough to like like detain him, but not like,
When he had like
Big thing.
16, I think St.
Yeah.
Joe's ended up counting 16
it was like 16 gunshots.
gunshots, and he
Yeah.
survived.
Yeah, so yeah, he came back, just this month for I think an infection, a wound
Oh,
infection.
did he see you?
No, but I saw in the, oh no, yeah, I think, I think it did see him,
I
yeah.
saw a follow-up note, I thought from you, I couldn't
Yeah,
remember.
so, yeah, like I said, the nice thing is like, he missed everything vital minus the neck fracture, so neck fracture was kind of the only thing. Luckily, I didn't think it led to any neurological deficits, so it hit the vertebral body but didn't get the spinal cord. So he got really lucky, the fact that he even survived this, but he also got lucky that no neurological deficits from his injury. I think he did have, he's the one that had a really bad like elbow fracture from the.
He had both extremities, he was shot in like all 4 extremities, and it got his scrotum, and then he had, I think one like went through here and into his axilla, and then it landed in his C6 or something like that.
That's probably where all the neck hematoma was. So somehow that magic bullet went from through the axilla out into the spine. So, let's see. Cause yeah, so this case sort of highlights one of the things that we see very commonly, which is hemorrhagic shock. And they, like I said, that was quick identification. They stabilized them. The other thing they saw was obviously he was desaturating, obvious penetrating trauma to that left chest. They put needle decompression. Immediately saw results of that. So overall, this is just like a really great case. I feel like they identified the problem very quickly, intervened, and because of that, he actually had a very good outcome by the time he got to us. Yeah, so when the nowadays, everything is based off blood administration, so we've kind of shied away from doing fluids or crystalloid fluids, and the reason being is there is thought that if someone comes in hemorrhagic shock and you're giving them crystalloid, you're just diluting out whatever's left in their tank, blood clotting factors, red blood cells. It's different when you're on the field and that's all you have, so it's like a different story versus when you're in a hospital and we have immediate access to blood. But there are actually some states that allow for whole blood to be administered. Oh yeah, and then yeah, so the other thing, good point, is warming these patients. So keeping these patients warm also helps because there's a thing called a triad of death, which is acidosis, hypothermia, and coagulopathy. If you have those 3 things, you're gonna die. So like there's like instant death because it means you can't clot and you're just gonna exsanguinate, and then your body becomes more and more acidic, your brain stops functioning. So when those 3 things set in, it's like almost beyond salvage. So when we reverse all those, we try to keep people warm. We obviously give them clotting factors to kind of replace that coagulopathy, and then we try and reverse their acidosis with fluid resuscitation, blood resuscitation, as well as occasional body trauma and things like that. So we address all those 3 things whenever we resuscitate these patients. But you bring up a good point about keeping these patients as warm as you can keep them. Okay. I know here it's easy in the summer, but in the winter it actually can get pretty cold, so it's important. Trying to think if there was anything else for this, but yeah, and then the time from the field to the hospital is also important. And this was like less than 20 minutes, so this is a fantastic case. So I don't think we really have anything else for this one. It was just kind of like, this was just a nice case because it's like, one, it's a dramatic one, but 2, it has a good learning case for hemorrhagic shock and management of hemorrhagic shock. Yeah, so then I was saying that in some states they're actually allowing certain EMS crews to carry around bags of blood or whole blood that they can easily administer in the field. That's still kind of like, I think that's being tested. I think PA had that when I was over there. They were kind of testing it out to see if it affects obviously outcomes and how feasible is that. So obviously here we don't do that, but that's something in the pipeline that may change, maybe the next 10, 20 years, depending on those studies and what they find the outcomes to be. So any questions on this case or any thoughts on this case? This is just kind of a little bit dramatic case with the way it presented, but also I think it highlights a very important physiological condition we see a lot is hemorrhagic shock. So. All right, last one is this is a TBI case, which is also very important because traumatic brain injuries are also kind of time expedient. This young lady's 20, she was crossing over the border, fell from the top of the border, which is around 30 feet, landed on her head, on presentation, oh, sorry, is there a question? Yeah. Yeah, so, yeah, right now it's still kind of it's just being tested out in a few states. Just to see if it has an impact on outcomes, so. But yeah, so this young lady was out on the trying to cross over, fell off the border wall at 30 feet, landed on her head. The timeline of this is very unknown because this was out in a remote area of the border wall. So no one knows when she fell, how long she was out there. By the time she was encountered and evaluated, she had GCS of 7, the placed a C collar on her, brought her on a non-rebreather. She had a head lac that was stabilized with dressings. So the point of first contact was around 1629, but because this was sort of a little bit off the beaten path down and along that border wall, it took, I think, almost like 30 minutes to arrive at the hospital. And that's just by the nature of the distance between here and that. On admission, she was intubated, she was hemodynamically stable. We were able to get her to a CAT scanner really quickly. Ended up finding she has epidural hematoma, which is obviously the more dangerous one of all three. She also had a subarachnoid as well, which was not as vital, not as important in this case. Surprisingly, the rest of her studies all came back negative. So she had no other injury except for this massive epidural hematoma. So we gave her a dose of mannitol because obviously we didn't know the time frame from when she had this. And now we have to transfer her an hour and a half. So mannitol is a drug that we can give that will help alleviate some of the swelling of the brain. This is all given here in the hospital. It's kind of hard to give this in pre-hospital, but I just want to give you guys an idea of what we use here to help. So mannitol will help kind of diurese out some of that fluid. Sometimes help decrease the swelling because as the brain swells from the hematoma, you're increasing that pressure inside that brain vault, and then you start to lose blood supply, and that's how the brain dies. So what part of the treatments for anyone outside of like neurosurgical treatments is mannitol 3%, all that sort of dries out the brain, so that way the brain doesn't expand and cause ischemia to the brain tissue. So she ended up getting transferred to tertiary center. I think she had a craniotomy. She had evacuation of epidural hematoma. She was there for like 2 or 3 weeks in some sort of neuro rehab. But I think that's as far as an update I got. So I'm reviewing this case like well after.
And I think this case was one that, if it was Dr. Naroyan, he was talking to me about drilling burr holes.
Yes.
And writing a policy on it, because he's like, if that's your last ditch effort to relieve the pressure, I mean, it's our last ditch effort. And I was just like,
No.
please
Do not
don't
do
start
that.
drilling holes in people's heads.
And I know some ER docs are trained to do bolts where they do intraventricular pressures and to release, but no, yeah. Yeah, I think you're talking about the whole blood,
The
yeah.
mantle.
I think for blood is what?
So blood, it just depends on the temperature. I don't know how long, like your packed cells are good for and your plasma. Platelets do not have a very long shelf life. Cryo, as soon as it is thawed, it expires in 4 hours. So that's why too, like when we're rapidly transfusing patients and giving them all of these blood products, before you know it, you can be 27 units of blood products into a patient and their outcome is death. And you just wasted 27 units of blood products that you don't have now for the next patient. So those are kind of difficult situations for us when we're in the hospital, patient has a pulse and it's like, if I quit giving them blood, they're gonna die.
Well, and I think what they're studying out in some of the other states for EMS to administer blood is actually whole blood. And I think that actually has like a shelf life of like 8 hours. So yeah, it's a good question. And these are all just like preliminary. This is just more like places trying this out and figuring out how feasible it is and whether it's even something that could be sustained. So this is like, a possibility, but there's a lot that goes into that.
And we
So-
can transfer patients by flight with blood as long as we have it packed in a certain storage container. As long as that blood doesn't get opened and it remains at temperature, the flight crew can bring it back and our blood bank will put it back in stock as long as it's the right temperature. The only thing, the times that like it gets kind of frustrating is when we start sending 4 units of packed cells, 4 units of plasma for an hour-and-a-half trip with flight agencies that don't have rapid infusers. So it's not really feasible that they're gonna put all that blood, cold blood on top of it into that patient. So kind of a thought process.
So anyway, so learning reports, this lady obviously had a severe TBI. The key findings obviously was her mechanism. She had fallen from the 30 feet. She had a GCS of 7. I think there was one report of GCS of 6. So I gave her the best number of 7. So, oh yeah. Thank you, appreciate it. And then she also already had a non-reactive right pupil. So we kind of, when you see this sort of presentation on the field, you automatically have to assume they have some sort of head injury. And the quickest you can get them to us, the better, because there are things that we can do for them here even before they get to their terminal location for a neurosurgical intervention. And that's mannitol, 3% saline. We kind of dry out that brain to kind of maintain that pressure low. So by the time they get over there, they can actually intervene and save that brain tissue. So that's why this was sort of a nice learning case, because even though the scenario was bad, because this lady was out there for God knows how long, and she was way out there where it took her 30 minutes just to get to the hospital, just by the nature of the distance, you know, we're still able to intervene and save her life, because had she been out there maybe a few more hours, like she probably would have herniated and died well before she had a chance to make it to the hospital. So I think this just highlights a very good, you know, immediate evaluation, stabilization, and transfer. The other thing too, there's things that you guys can do. And the reason, and the big things are maintain proper C-collar, because if you assume they have a head injury, assume they have a neck injury, unstable neck injuries that you malmanipulate can cause internal decapitation and kill the patient. So I always say, whenever you have somebody who's assumed to have a head injury, assume they have a neck injury, stabilize that neck, get him in a collar. High flow oxygen is very important, because as the pressure in the brain increases, you start to get vasoconstriction. High flow oxygen actually helps maintain those vessels open and avoids vasoconstricted blood loss to the brain. And then IV fluid resuscitation just to maintain that pressure so they can freeze their brain. So all these things you guys can do that will help. And then by the time they get here to us, we can do anything else necessary and then stabilize it for transfer. So.
May I add a couple thoughts on the brain
Yeah.
injury?
Yes.
So for the providers in the room, can anybody remember what the 3 H-bombs are that we learned from epic traumatic brain injury lectures?
A little shy.
Yeah, so there's three H-bombs that they keep teaching us in epic traumatic brain injury: avoiding hyperventilation, so making sure you're monitoring end-tidal CO2 continuously and very strictly. And does anybody remember what the parameters are? We want to maintain end-tidals between what and what?
30 or 40?
Close, 35 to 45. Because we want to avoid hyperventilating. Some of you may remember when we were first taught in EMS in our CERT classes that patients with a blown pupil, with a low GCS, unconscious, unresponsive, we were taught initially to hyperventilate these people, to blow down their CO2 and try to create some vasoconstriction so that their brains don't swell and we can get them to the hospital without herniating. That science has been debunked. And it turns out that if you hyperventilate these people, you can double their mortality. And so hyperventilating is a strict no. EMS agencies are encouraged to have their providers use cadence lights when it comes to ventilation rates, so that they're not ventilating more than once every 6 seconds for these people, and to track their ventilation strictly by the end-tidal CO2. The second H-bomb is avoiding hypotension. Any single blood pressure below 90, systolic below 90, quadruples your mortality with severe head injury. And so making sure that you're getting your BP readings every 5 minutes and getting ahead of any trending towards low BP with your crystalloids. And the third H-bomb is hypoxia. Any single saturation below 90% also is devastating for mortality. So making sure that you're getting them on high flow oxygen early, making sure you're securing airways early. And then the other pieces are making sure that you're correcting any hypoglycemia. That's the other thing that you can do to help give these people the best chance possible.
Perfect.
And being that this patient was, I don't know exactly where she was down by the border, but would this be somebody you guys would just consider, being that she's unresponsive, calling flight to the,
I think that call was,
Depending on the level of, yes, we would call out for a helo. Probably unavailable at the time.
yeah, I think this one was, they couldn't access it through, this normal way, and they had to drive 5 miles down the road to gain access to the wall, and then drive all the way back to the patient and then come back the same way. And I think they even tried Border Patrol and see if they could transport, and first, I think it was a cascade of several circumstances that they couldn't get somebody there fast enough. Yeah, but it took a long time. Yeah, because we talked about flight. And it ended up being like near the range over there, like coming down 12th and
It's a little bit far south of this.
yeah, like it was back in the back over there that they couldn't, the access was bad, so they couldn't get flight, or there's nowhere to.
Yes, I was gonna try to kind of capture all those border wall falls or border wall related injuries, because it is an interesting population that we deal with because of that. The access to those patients can sometimes be hours, and obviously trauma is built on hours, built on minutes of intervention to save lives. So it is a kind of a unique case to address whenever you get those patients who fall border wall. So but yeah, so I thought this was a great case because this lady, otherwise, like, did all the right things when they saw it stabilize. I didn't mention, but they did check for hypoglycemia on her too. But they did all the right things. Stabilized the seat collar, got her on high flow oxygen, fluids running, straight to the hospital. We were able to give her mannitol here just because we didn't know how long she had been down. We didn't want her to herniate. Mannitol will help try to at least kind of stabilize some of that pressure, get out that pressure off the brain. And then that way we can get her up to, I think she went to St. Joe's. I think St. Joe's where she went, and she got a craniotomy, evacuation of epidural. So, yeah. Cool. I think that was I think it's the last case I have. See, click on the,
Click on it.
yeah, so I just give that nice, kudos, because that was a very ideal and expedient for this lady. So obviously, you guys play a very important role in our stabilization of our patients. Hemorrhagic shock is the major cause of mortality. It is very easily treatable with appropriate blood administration. So urgent presentation, bringing those patients to the hospital as quickly as possible will help play a role in initiating their treatment. And then obviously, we talked about the pre-hospital ROSC is the biggest indicator of good outcome versus no ROSC is a poor outcome. So that's why the documentation is very helpful. So. Questions?
what is the thought of pre-hospital carrying TXA locally? And I mean, I was watching the Stacks convention last year, and there was different surgeons, and some were in support of giving TXA, some were saying it's not really all that beneficial, and then some were saying it's only really beneficial if you give it pre-hospital. So is there, I mean, I think it's in their scope.
Because it's all based on the crash trials. There's 3 crash trials. Crash 2 is where they tested TXA, I think, with hemorrhagic shock. And that's where they actually saw a survival benefit. And crash 3 is the controversial one for head injuries. And the reason being is that there was some potential benefit in head injuries, but a lot of people sort of have a lot of, how to say, quality questions about the study. And because of that, they don't take it for face value. So TXA for someone in hemorrhagic shock, I'm all for, because we have it built into our MTP, because TXA is one of those factors that help clot. But TXA outside of that, it does have a risk of clotting, spontaneous clotting, so you have risk of P's, DVTs, and all that stuff. It's not high, but it's not 0 either, so.
So on the EMS world, make it just, we've had conversations on, about it. What I think we started like 2 years ago, we kind of mentioned it, Doc, if I'm correct.
Yeah, Yeah, it is approved and it's in scope for the state of Arizona, but the protocols that we use, we do not recommend, we do not approve its use for isolated head trauma. And it is to be used in patients with suspected hemorrhagic shock or at risk for suspected hemorrhagic shock, as long as it's given within the first 3 hours. And there's dosing parameters already approved for TXA.
Then I'd say I would agree with that. Because like the head injury one is always the controversial one. That's the one that's been like batted back and forth between different people. And you'll have always a mixed opinion on that crash-free trial.
Well, I was listening to the presenters at the convention and I'm like, okay, so what's the answer? Like, because they were going back and forth and I'm like, well, that doesn't help.
So I err on the side that we have better proven like interventions for head injuries than TXA. So I just think TXA is not in the algorithm, at least for without neurosurgery. Because the thing is, if you have neurosurgical intervention where they can go in and evacuate that blood, then TXA may be helpful with helping clot if there's something bleeding. But without neurosurgery immediately available, I would not give it to them. Because like then you're just kind of throwing something at the wind, hoping that it stops, but you don't actually have that terminal treatment, which is surgical intervention. I think mannitol 3% saline is probably the best way to preserve brain rather than TXA. TXA just stops bleeding, but you know, you still have pressure from that hematoma. You still got to get that hematoma off. So.
Okay, Doc, just as a conversation, I mean, when me and Megan talk about some of these, we talked about some of these cases and she comes up to me with the, you know, codes that they worked and bring in. We definitely try to talk to the crews. I think it's more of, we need to get more confident with our assessments. And that's, I know for a long time before, and then all the old regime here is that you brought everything in and you got to bring everything in. And I think some of that definitely needs to change. We definitely have less of those cases coming in, you know, they're calling more. They're making decisions. So I think it's a for all those on Zoom is just be confident in what your decision is. Don't, you know, if you get there and they're asystole and apneic and everything else, I mean, you're doing the right thing by making those decisions. So I think
that when you think of it from a systems perspective, if you just back up your thought process, you know, a couple steps. I mean, as I was hearing about that motorcycle crash and kind of hearing about, oh yeah, you know, we start, you know, mass transfusion and we spent, you know, 2+ hours and this and that and the other. I mean, imagine what that's doing to your area as a system. The taxing of resources, the using of blood, the code 3 drive for 45 minutes from San Luis or wherever the heck it's coming from. I mean, this is just a massive toll for somebody that is not survivable. And so it is about having confidence in your assessment. It's about understanding that your responsibility as a frontline medic is sometimes bigger than just one patient with a futile, unsurvivable injury. And yeah, the old school, you know, rule of just everything comes in. No, that's not evolved thinking. It's not evolved thinking. It's not modern thinking, and it's certainly not evidence-based thinking.
Yeah, don't believe we're not coming after you. We're learning from every case, and that's what we're trying to do, right? So, yeah, nobody's coming after you. You're making the right decision. Trust your assessments, and that's it. So, the other thing, you mentioned warming people, and I think we talked about it last year in the September chart. Is that you guys don't see what happens 4 hours later. And that's when we start seeing those DIC patients going ARI and Cody, is that keeping them warm makes a difference. You know, so even in the summer, I mean, even in the summer, so cover them up.
Yeah, it's a tough place to be, and I don't envy you as a frontline medic, and you know, sometimes working by yourself with a patient who's super sick. I mean, you guys are in a very tough spot, but you know, obviously it's important to expose these people to understand what the extent of injury is and where the life threat is coming from. But at the same time, once you've identified and you've got a certain handle of what's happening, then, remember the language we used during that September lecture last year is assume they're losing heat at all times. And so once you've got the life threat addressed and your tourniquet's on and your fluid's going and your chest and your needle decompression's done and you're driving in, then pivot some resources and some thought power to preventing heat loss. So you're not in that triad of death.
Thank you, Doc. Appreciate it. One of the things coming up, guys, next month, I sent out a stroke PowerPoint, should be playing. Please send me a roster once you guys are completed with it. That's for our stroke DMV certification. So please review it. And then in September, we're going to have our next taping chart's going to be, we kind of lax on the transfer of care that we had, worked on. So we're going to try to do mock codes and get more involvement from our side too, from the hospital, more MDs, more our nurses to come in and some of the techs. So that's for September. And after that, Stacks comes in November, and that should be it for the year on tape and chart. So appreciate it. Thank you for your time, and we'll see you later.
One thing,
Oh,
do you guys need anything from us, like in terms of like, do we need to change any processes that will help you guys with what you guys are doing? Like sometimes it's if we don't have that avenue of conversation, we obviously will never change anything, but it's always good because it's a back and forth relationship. So if you need something, if you guys need something from us, feel free to ask for it. At the end of the day, we're trying to accommodate each other so we can give the patients their best care they can receive. So if there's something that we're not doing that you guys would benefit from, just let us know. We're happy to try and oblige and adapt to those, okay? Thank you.
okay. For Zoom, send me an email, no text, please. Send me an email. That way I could have a record of your insert number, full name, please. Thank you.
Yeah.
You're on the.
For discussion.
And yesterday I had clinic all day, like, when you get through, you have my, being, I got vaccinated.
And that's
I really had to work on
I
it,
think we
like,
talked about it when we did.
Luckily, I saw every time
we
I
were talking
do
about
a
these is that you,
I
like you,
my epic list.
they do 8
of
minutes,
reviews,
8
so I
to 10
only
minutes
have
of the.
all our trauma cases.
Oh, good.
It was done because they didn't wanna start sending.
Thank you very much.
So that was when we started. You don't get anything, you're done.
Okay.